We have two invited testimony, Jamie Dudensing and Dr. Sue Bornstein. It's either Dr. Bornstein or Dr. Bornstein, so please join us. If you would state your name for the record, and you may begin your testimony.
Good afternoon. My name is Jamie Dudensing. I'm the CEO of the Texas Association of Health Plans, and we are testifying in support of Senate Bill 1135. As many of you recognize, I've been doing this for a while, and over the past 10 to 12 years, we've been moving to something we call value-based care. And that's where you stop just paying for sick care, almost rewarding only paying when someone's sick, and you start paying for health care or keeping people healthy. And a big part of that solution is really around primary care, who we consider to be almost the quarterbacks of health care when we deal with patients and coordination of care and these pieces. We've watched this movement to value-based care with Medicare, with Medicaid, and a little over a year ago, Dr. Bornstein asked me to join a group of stakeholders that don't always agree on everything, the Primary Care Consortium, to come up with a solution on how we could better invest in primary care. And on one of the very early meetings, I was asked, why are we not doing this in the private market? Why is it not happening? I went back and asked. I have found out it's not allowed. Over the many, many years of state laws that happen that build on things, it's allowed in one type of product, the HMO product, but it is not allowed in an EPO product or a PPO product, which is what most people have. And I brought it to them and I said, I've been doing this for 20 years, I had no idea. It was one of the many solutions that we all agreed on for session, us working with the primary care docs to find a better way to pay for primary care. And I will say that a big part of this showed up during COVID-19, where primary care docs that had this type of model, where they received a set monthly amount payment, where they didn't have to worry about claims, they didn't have to worry about PAs, and they were just being paid to keep someone healthy, they would call a patient, text a patient, have visits. They had a viable financial source, and they were just keeping their patients happy, whether it was at home, in the office, whatever needed to happen. But the primary care docs who didn't have this solution did not have that same advantage. So I'm happy to answer any questions. We hope for your support for Senate Bill 1135. As Senator Swartner mentioned, it's one of the times that we are working with primary care docs on a solution to help really advance primary care for Texas.
Thank you. Doctor.
Thank you. Good afternoon. Thank you, Chair. I'm Dr. Sue Bornstein. I'm an internal medicine physician from Dallas. I am the co-lead of the Texas Primary Care Consortium, which advances comprehensive and sustainable primary care for all Texans. And thank you, Dr. Swartner, Senator Dr. Swartner, for bringing this forward. Really appreciate that. So Senate Bill 1135 would allow PPOs, preferred provider organizations, and exclusive provider organizations, also EPOs, to engage in value-based payment programs, including risk-based payments. So why is this important? I think Jamie and Senator Swartner have already alluded to this, but the traditional fee-for-service payment structures reward physicians who deliver high volume, sometimes high-cost care, and they do undervalue comprehensive, continuous, and coordinated primary care services. And I just want to point out that value-based payment models really come in all sizes and shapes, from things like pay for reporting, to bundled payments for episodic care, to full capitation for a patient population, to things like direct primary care, which is essentially a monthly subscription fee, sort of like Netflix, for a defined set of primary care services. Senate Bill 1135 would allow health plans and physicians, if they choose to do so, and that is really key here. I want to emphasize, we are talking about voluntarily engaging in these types of arrangements. It will allow us to test innovative value-based payment and delivery models in the commercial market, as has already been said. Medicare is way ahead of us on this, and so is Medicaid in Texas. So health policy experts across the political spectrum agree that reforming the way that we pay for primary care, again, to incentivize quality over quantity, could help contain increasing healthcare costs and improve patient outcomes. This bill is smart public policy. Healthcare costs are a problem, and we need to change what we pay for and how we pay for it. Senate Bill 1135 allows us to change the way we pay for health care. In closing, I want to share a quote from the landmark historic report on primary care by the National Academies of Science, Engineering, and Medicine. To improve payment for primary care to better meet people's needs, payments should be increased to reflect the outsized benefit that primary care has on the health needs and well-being of society, and flexible enough to allow practices to meet the specific needs of the populations they serve. Thank you.
So I couldn't agree more that if you have a great primary care physician and you can get access to him or her, you can really ward off major problems, right? I'm blessed to, have the cell phone of my primary care physician who was born and raised in, I think, Austin County, but is practicing in Washington County. And you can do little things like, say, whatever, blah, blah, blah. You don't need to come in, do, blah, 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 whatever. But they should be paid for that constant contact, right?
Exactly.
But it could save insurances money while also improving the overall outcome.
I think you got it.
I just, we talk about that. We've been talking about this since Bend the Curve came out, good gosh, what was that, 2008, 2009? I don't know that we're bending the curve. I keep asking, if we do biomarkers, is that going to improve, cost eventually? So do you think we could save money with this?
Jane, go.
Either one of you.
Well, I will say, and I don't remember these numbers exactly, but I do know, for example, the state does something similar with ARC through the ERS program, and they report savings year after year to the state of Texas for having a quality-based, risk-based, shared savings type of model with the state of Texas. And that is not, but we can't do that same thing in the PPO market. So yes, you are seeing that. And I'd be happy to chase down those saving studies for you, or I'm sure ARC would love to share that. But yes, you do see it.
Worthy conversation. My next question is going to be, do we have enough primary care physicians? Senator Blanco is working really hard on some bills that would, change, who delivers this. But what's your answer on that? Because I don't think we have enough primary care physicians to maybe pull this off.
Primary care is a team-based sport, if you will. And so I think that you're right. Texas has a shortage, acute on chronic shortage of physicians, especially in our rural areas. I think that there are creative ways that we can incentivize folks, whether it's loan repayment or things like that. Now, you all have talked about telehealth some. That is one tool, if you will, in the toolkit. So I think there's some creative ways that we can do this.
Jamie?
I was going to add, creating more innovative ways to pay primary care where you are getting a set monthly amount. You're not just waiting for a patient to get sick, but you are able to pay them for their effort to keep their patients healthy, make sure their wellness screenings are happening, make sure their chronic conditions are managed. Changing the way you pay for primary care can make it a more advantageous area of medicine for doctors to choose to go into.
Thank you all. Members, any questions? Senator LaMontea.
Thank you, Madam Chair. I have a question about the health plans. So the monthly fee that would be paid for this program, would that be accounted for in the individual's accumulators regarding out-of-pocket or their deductibles?
It's a very good question. I really will have to get back to answer that question, but a lot of what I have come to understand about these types of models is that you really don't have out-of-pocket cost associated with them when you're paying that monthly amount to the provider's office. Yeah.
And then in regards to the question about do we have enough primary care doctors, the other question is that do you see, in the medical field, with doctors especially, it takes a while for new ideas to kind of, become acceptable. I think the medical profession is the ones keeping fax machines alive. So do you see a lot of doctors willing to enter into this type of model?
Absolutely. And to Jamie's credit, bringing this forward, it was a major light bulb moment because, from my point of view, we've been advocating for advancing primary care for years, and it was like, okay, it really can't happen that way. So yes, I think that there are many, many practices, many physicians, and they could be in a small practice, independent practice, big group practice, they're excited to do this. They want to take care of their whole population. And that's really, again, I don't want to get into all but that's really what we're talking about. We're talking about taking care of the patient that's in front of us right then, but we're also looking at our entire panel of patients. But in order to do that, we have to be able to reach out to them, as Jamie said. You need your mammogram, or you need this and that. And that, it's calculated that a primary care doc would spend 18 hours a day doing all that, him or herself. And so that's why, again, we're strong believers in team-based care. We need a team to do this, but that costs money.
Also to go back to, we already offer quite a few of our products on the market right now, even without this, have gone to low dollar or no out-of-pocket cost for primary care. We've been cutting copays for primary care in the first place. So I think you would start to see it more and more either way. Thank you.
Senator Sparks.
So for clarity, I actually have a contract with a physician, right, one-on-one, and then I also am participating in some type of health plan as well for like catastrophic care. Is that the way that looks?
It can look so many different ways. What I would say in a commercial health insurance world where an employer is paying us for that total amount and they're expecting us to pay for that primary care, we would be then paying that provider that monthly amount. More likely, it could be a subscription amount, like she mentioned, or which we kind of consider some direct primary care, or something we call advanced primary care, where that provider takes on more risk. It could also, and that can be a model where they have shared savings. So if they reduce ER visits, we share that savings back to them. So there's multiple.
A lot of ways you could carve that up.
But we have to be very flexible because not every primary care group is ready, or that's why it has to be so voluntary. You have to meet everyone where they're at.
Thank you.
Thank you.
Thank you.
Thank you.